Good afternoon, and welcome to the Precision and Population Health Fireside Chat. I'm Melissa Bondy, Chair of the Department of Epidemiology, Co-Director of the Center for Population Health Sciences, and Associate Director for Population Sciences in the Stanford Cancer Institute. And I'm delighted and honored to have this opportunity to discuss the topic of precision health with Dean Miner. As you know, Dean Miner has been in the forefront of precision health and recognizes its importance for the future. And I cannot think of a better person to kick off this initiative. So just a little background about me. When I was interviewing for the job here at Stanford, I had a really great discussion with Dean Miner about precision medicine and how we both saw the importance as a future direction of healthcare and beyond, especially here in the Silicon Valley. The goal of this fireside chat is to set the stage for how the Center for Population Health and the Department of Epidemiology can build stronger ties with centers and institutes across the university and potentially collaborate on innovative grants in precision population health, as well as having a broader reach in the community. Precision health means different things to different people. And for us in the Center of Population Health Science, we're focused on advancing health equity. As an example, we leverage big data sets. They could be genetic data, data from digital gadgets, claims, and population data, using novel methods, including AI and machine learning, to create tailored, effective interventions and policies that can move the health equity needle in a positive direction. We are applying the latest data science innovations to better understand and address social and environmental factors that affect health disparities. And much of what we do is precision population health. This fireside chat is the first of a seminar series that we will be hosting on various topics, including a precision population approach to health equity. And just as a reminder, we'll cover the pre-submitted questions. And if you have any questions during the talk, please submit them in the Q&A box and we'll address those if we have time. So let's just get started. Dean Miner, thank you so much for being here. And I'm really excited about this fireside chat. So last March, you published a book called Discovering Precision Health, Predict, Prevent, and Cure to Advance Health and Well-Being that addressed much of this topic. Can you share a little bit about the book's central theme and what inspired you to write it?
Well, thank you. Thank you very much, Melissa. And I want to say how excited all of us are, Melissa, that you joined us here at Stanford. You're doing a fantastic job leading the department and leading our initiatives in population health. And I just couldn't be more pleased to have you here and to have you as a colleague and friend. And I've been looking forward to this fireside chat. So the book came about, when I came to Stanford, I started as dean in December of 2012. And of course, I wanted to get to know people in the environment and learn about where we were then and where we wanted to be. And this was around the time, actually in the spring of 2013, that UCSF, when Susan Desmond-Hellmann was the chancellor, hosted a conference on precision medicine. It was the first time that I'd seen those two words grouped together, precision and medicine. And I attended the conference. It was very exciting. It was mainly about how genomics and data science were being used to tailor and individualize the care for severe complex diseases, such as breast cancer, other cancers, certain forms of heart disease. And certainly precision-based approach, computational approaches, genomic approaches have revolutionized our treatment of many severe acute diseases. And shortly after the conference hosted at UCSF, of course, President Obama came out with a precision medicine initiative for the country. We talked about that here at Stanford, and certainly we do precision medicine here, and a lot of advances in precision medicine have originated here, including the fact that the biotech revolution here really began in the world, really began here at Stanford with the work of Paul Berg, then of Stan Cohen and Herb Boyer, and so many others. But we wanted to go beyond precision medicine, that is, go beyond focusing on severe acute diseases and really look at predicting and preventing disease. And yes, when we are not able to predict and prevent disease, we want to be able to cure it And we want to be able to do all these things precisely. So really the approach in precision health is to predict, prevent, and cure precisely, but with a lot more emphasis on prediction and prevention than we've traditionally seen perhaps at academic medical centers in the past. And we began to shape this vision, and we'll talk a lot about that during our discussion this afternoon. And then that led really to the book, as you mentioned, that came out in March of 2020, last year. Of course, last March, we were doing a lot of other things other than talking about a book. But anyway, I do have a copy of the book here. And, I guess that doesn't work so well with the virtual background. But, okay, well, you can look up online. Just to mention, all the royalties from the sale of the book go to Stanford University and to benefiting our programs here. But it really talks, I would say about 2/3 of the book is about Stanford people. And then 1/3 is about entrepreneurs and companies that I've encountered and had the privilege of getting to know and interact with here, looking at this space of digital health and other related areas of applying technology to improve health and healthcare. That's how the book began and how the vision began. And I think we're seeing it take form. And I guess the take-home message is this: precision medicine is about sick care. And for sure, if we have cancer or another severe acute disease, we want precision medicine. We want treatments that are tailored to us as individuals and tailored to the characteristics of our disease. Precision medicine, therefore, is about sick care. Precision health is about health care. It's about how do we keep ourselves healthier and in good shape, out free from disease, or if we can't prevent disease entirely, then how do we diagnose it much earlier and therefore treat it more effectively?
That's a great answer to that question. And I think we share the same things, where in our areas, we want to start taking it back a little bit so that we can prevent and we can identify at-risk populations who are really at risk of getting diseases that we might be able to think about preventing. So as Dean of Medicine, you have been committed to population health, and I think it's pretty clear that you put a lot of resources into our department and to bringing quite a few people here to carry on this vision and this dream, and I'm hoping that I can carry that forward. And you've emphasized the importance of social determinants of health. What's led this to your decision? And I think the timing right now is so important of what's going on in the world, and COVID and other kinds of things is, the importance of population health and how we look forward into dealing with social determinants.
Thank you. Well, we know from innumerable studies that roughly 70% of the overall determinants of health and well-being are related to the social, behavioral, and environmental determinants of health. Any study you look at, the literature better than anyone, Melissa. And certainly it was true before COVID, but my goodness, COVID has really underscored that. In terms of, you look at the outcomes of people who acquire COVID and the mortality rate, the incidence rates of infection, all directly linked to social, behavioral, and environmental factors. Only about 30% of the determinants of health are related to the medical care we receive and our genetics. And of that, probably the larger component of that 30% is genetically related. Only 10 to 20% is related to the medical care we receive. Now, I'm not suggesting for a moment that we should back away from providing the very best medical care, and indeed providing the most technologically sophisticated and scientifically informed medical care, which we're known for here at Stanford. But unless we also address the social, behavioral, and environmental factors of health, we're never going to have the type of impact that I think we know we can have on overall health and well-being. And so one of the things that I think we're in a unique position here at Stanford Medicine to do is to take a broad and holistic approach. And medicine and public health separated for understandable reasons way back in 1914. There was a conference hosted by the Rockefeller Foundation Of course, in 1914, infectious diseases were still rampant. Lots of things were, in fact, is in 1914, there wasn't nearly as much that one could do as in terms of impacting human health in medicine or in medical care, whereas there was a whole lot that could be done in terms of hygiene and overall public health measures. And that's the outcome of that conference was a recommendation that there should be a separate public health curriculum, separate from the medical school curriculum. And so schools of public health arose and thrived. Medical schools also, of course, became much more scientifically focused. And the two disciplines have really evolved and advanced in parallel, sometimes coming together, but more often than not remaining distinct from one another. And in many respects, that makes sense. The approaches sometimes are different. And for physicians, of course, first and foremost, we want to make sure we're delivering outstanding care to the patients who entrust their care to us, the individuals. But what we've seen is unless we address the public health measures, and again, COVID has underscored this, unless we address those in parallel with the individual health needs, we're not doing service to our patients. So I hope in the future, this dichotomy between public health and medicine will become less and the fields will converge in ways that actually promote health and well-being. And I think we have a unique opportunity here at Stanford to do that.
I think so too. And that's really what the goal of what we're hoping to do, of bringing together people from so many different institutes and centers that have that ability to be able to do that. And I know that some of the things you say, it's your zip code that means more than it is, other things in terms of the health disparities and how we look at that. And I'm hoping that we're able to reach those communities and, try to identify ways that people gain trust in Stanford and how we do things. And I think that's really, the goal that all of us are hoping to come by. So in your book, you write that a better understanding of social determinants will enable more precise approaches to disease prevention. Could you share a little bit about that and the potential for population health to address these disparities?
Sure, there are some stark statistics that are worth remembering. If you just take a relatively small geographic area like Washington, D.C., the District of Columbia, there's as much as a 33-year difference in life expectancy between different neighborhoods in the District of Columbia. It's shocking, and it should be completely unacceptable in our country. And you don't just have to look at Washington, D.C., look at a variety of other metropolitan areas, other areas in the United States, these stark differences. And of course, they track directly, the differences in life expectancy track directly to socioeconomic factors. We still have, within a relatively short distance of where we live and work here at Stanford, we still have areas that have food deserts. Certainly, we've seen areas in which testing has been scarce. We've done a lot through our healthcare delivery system to address that. And also in the state of California, we've seen marked disparities in the uptake and distribution of vaccinations for COVID related to socio-demographic factors. Those are some of the examples, but so what are some of the common social determinants of health? Well, certainly access to healthy foods, access to health care. It's easy to talk about living a healthy lifestyle and getting exercise. It's much more difficult to do that if you're in a neighborhood where it's unsafe to be outside on the streets because of violence. I mean, these are all factors that have huge impact on the health of individuals and individuals in a population setting. And they've received comparatively little attention.
I can't agree more with you. It's a sad, but it's actual truth. So you published an article recently in Fortune magazine about the 5 numbers that are most revealing about racial disparities in healthcare. Can you share a little bit more about this and the potential for population health to address these disparities?
Yes, well, the 5 numbers are zip code, and it's a simple statement of fact. that the zip code in which a person lives is more predictive of their life expectancy than is their genetic code. And again, this relates to these marked disparities in environment, in living situation, and other social and behavioral determinants of health. Now, we've seen here at Stanford already, and I know there will be even more in the future, Melissa, with your leadership and the amazing people on the faculty who are working with you and the students that are being attracted here because of the programs that you and your colleagues are building. But we've seen already at Stanford examples of great research and programs designed to address those disparities and inequities. Programs such as the SPHERE program, Stanford Precision Health for Racial and Ethnic Disparities. That SPHERE has sponsored studies such as offering for, we know, for example, among the Latinx community that over a third of adolescents are obese. And many of these adolescents go on to develop severe health problems in midlife, diabetes, kidney disease, heart disease. And what interventions might help to combat childhood obesity? And we've seen faculty here offer and study the effects of offering smaller eating utensils to the families that have obesity, to test the hypothesis that, well, if you're cooking less food and serving less food, people eat less, and maybe there's less propensity for obesity. And the data show that that's exactly the case. I mean, these are the types of scientifically driven and innovative approaches that we need to be thinking about, as well as the more wide-scale deployment of technology to address social determinants. I'm hopeful that telehealth will be a useful intervention that will help to address some of the social determinants of health. It requires access to some form of a signal, either internet or increasingly a simple cell phone signal. But there are ways that technology can and should be leveraged to have some impact on the social determinants of health. Although I don't for a moment think that these issues are purely going to be solved through technology. They're much more complicated than that.
Well, and I think COVID has taught us a lot about technology and, how we use that technology, and more people are understanding it a lot better. But, I think also you mentioned SPHERE and our community outreach and engagement programs. And, it's one way, and some of the legislative changes that some of our research is doing. And we've seen some of that with the work that SPHERE has done, also the work that in tobacco and, many other things. And it's really, how do we reach the community and partner with them and gain their respects, and whether it's technology or whatever, but we have to think of ways that we really can impact the communities. And I think that it will take time, but as we start moving through this, it's really important for us to find the right partners and to be able to carry out our messages and be able to have an impact on precision health. So to date, precision health efforts have focused on developed economies. What do you see as some of the biggest opportunities for precision health to advance health equity in developing countries?
I think one of the biggest opportunities is emerging from COVID, and that is new, innovative, and highly effective approaches to designing, manufacturing, and distributing vaccines. That we now have 2 mRNA vaccines in wide use around the world is remarkable. Now, there's some challenges with those in terms of cold chain requirements, but that's going to be worked out, right? I mean, to think about the fact that that from the publishing of the sequence of the SARS-CoV-2 virus in January to when FDA gave EUA for the first RNA vaccine ever to be used, less than 11 months later, I mean, that's remarkable. And there are other advances in vaccine technology that are coming on the heels of the RNA advances. I'm really hopeful that vaccinology and had, I think, suffered and languished a bit over the past decade, 15 years. There wasn't a lot of R&D going into the development of vaccines or understanding the immune response, at least when one compared it to other areas of intense R&D in the therapeutics space. Therefore, I think we could hope for and reasonably expect that for a lot of the infectious diseases that are still ravaging the developing world, that we'll have new, innovative, effective, and certainly safe approaches to the development and deployment of vaccines in those communities. Whereas in the past, there was very little research and development activity addressing those existent infectious diseases, not to mention emerging infectious diseases. The other thing is the renaissance in diagnostics. We were really caught empty-handed and in a very ineffective position in the United States with the arrival of COVID in terms of our ability to diagnose the infection. And it's only now that we're beginning to catch up with the availability of diagnostics. And still, we need a lot of advances in at-home or point-of-care diagnostics. There will be a lot more emphasis in the research and development space in diagnostics in the coming years, I predict. And a lot of those are going to be effective and low cost to deploy in the developing world. I think the next decade could see tremendous advances in health and healthcare in the developing world as a consequence of the accelerant effect of COVID-19.
I can't agree more. I mean, we want to see what the silver linings are that's happened with COVID, although we know now that almost, over 500,000 people have died from this, that it's, at least in the United States, and even more around the world, that it's really a difficult problem. But just, in terms of the next question, let's keep on going a little bit more with COVID. So COVID-19 obviously is at the top of everybody's mind right now, and getting the vaccinations, getting things deployed. How can the intersection of population health and precision health help us navigate? And I think you've answered some of this already, but you might want to expand a little bit more, this pandemic to prevent the next one. And, maybe we're in a better place now. We have pivoted and moved quickly in terms of the vaccinology and these things, but we have to think about what's going to happen with the next one, or are we going to be able to pivot quickly to have every year we're going to have another booster for the same SARS-V, but as it mutates. But, I think that we have to think really carefully that we're on top of it and not left behind like we were with this pandemic.
Yes, I think if we first look at that topic and those issues in the United States, we have to rebuild our public health infrastructure in this country. Some of the most dedicated people I know in any aspect of life are the people who serve in our public health service, the people who are public health officers at county health departments in the country. They've been woefully under-resourced, and they haven't had the sort of national support. In a sense, they've had some support from the CDC, which is also an amazing organization. But this last mile problem of getting things from a policy recommendation level at the governmental level through the states and to the counties where the health departments are organized in our country, that coordination has been seriously flawed during COVID. I think we have to look with a new perspective on how we've organized our public health delivery systems in the country, and look to see what makes sense to leave strictly within the province of individual counties, and what makes sense to have a more centrally organized series of processes. Certainly in terms of the technology development, deployment, that I think there's a compelling argument needs to have more central emphasis and funding. And in parallel with that in our country, we've got to have a dialogue about how we absolutely protect individual rights and liberties, but also have the dialogue that we missed many, many opportunities to nip this pandemic in the bud in the United States. And we missed them because we don't bring health information together. We have very fragmented ways of sharing information, and our ability to determine when we need to implement quarantines, how to implement those, that ability is severely constrained in our country right now. A national dialogue about what the balance is between the rights of individuals, which we absolutely have to protect, and the need, again, at the public health level to make sure if we're really going to protect the rights of individuals, we've got to address the public health needs of the country more effectively than we have during COVID.
That's for sure. And hopefully we're seeing some improvement now and things are moving forward and people are getting vaccinated. So I'm hoping that we will see greater improvement in people's trust in the system. And I think that's been a major problem. So from your perspective, let's go back now to talk about Stanford. Why is Stanford uniquely positioned? And this is like, why are we uniquely Stanford? And now I kind of understand what that means, but maybe you can talk a little bit about how is Stanford uniquely positioned to lead in precision health and population health?
Fundamentally, it's our people. Everything at Stanford comes down to the people. We have an extraordinary faculty that attract amazing students. On the healthcare delivery side, we have outstanding leadership of our two healthcare delivery systems. We work together in a close partnership, myself with David Entwistle and Paul King, and we're all on one campus, at least the core activities. The engineering school, the biology and chemistry department of the School of Humanities and Sciences, great policy and economics initiatives in the law school, the business school, the economics department, the School of Humanities and Sciences. And Stanford has, I think, better than our peer institutions, has mastered this alchemy of how you make sure that individual schools and departments and disciplines have the autonomy they need to develop and grow in the ways that they need to develop and grow, while at the same time maintaining a level of horizontal continuity among schools, departments, divisions, to ensure that there's a whole that's greater than the simple sum of the parts.
Mm-hmm.
It's a tricky thing to balance at research universities. And I think it's never perfect, but I think Stanford on the whole does a really good job of it. Therefore, we can have, and we do, of course, have collaborations with the engineering school. Certainly during COVID, Professor Manu Prakash and his colleagues have developed, an at-home lateral flow COVID test that now is being tested in clinical trials, is being spun out as a company that could revolutionize the availability and low-cost nature of testing for COVID and then of other viruses as well. And so our ability to innovate and then bring those innovations into a clinical care environment is I think, unparalleled here at Stanford, and will continue to grow in the future as we build both our discovery-based enterprise and our healthcare delivery enterprise and connect the two with effective translation, as we're doing, for example, with the Innovative Medicines Accelerator. But it really does come down to people, and people with an entrepreneurial spirit, people who don't accept the status quo, but want to go further than the status quo and have real impact.
I think that really says it in a nutshell of what Stanford is about. And I never really understood when everybody said, oh, we're really small here. And it's really not that we're small, we're really an incredible community. And I'm seeing that more and more as I'm here, and just the collaborations. And it's you're right. I mean, we are unique and we have, strengths in just these collaborations with people all over the campus. And it's really exciting. So I was going to ask you a few more questions, but I feel like we owe it to our viewers and people who submitted questions. So I'm going to ask you a few of the questions that people submitted early on, and I don't know whether there's been any questions that have come in since we started. But one of the questions was, an important component in achieving equity for precision medicine is having scientists from historically underrepresented groups. Can you tell us a bit about the strategy of the School of Medicine to increase the number of underrepresented faculty?
Absolutely. There are several things going on within the School of Medicine, within, more broadly speaking, Stanford Medicine and Stanford University. One of the initiatives I would highlight is an initiative launched by the Provost's office, but very much with participation engagement of the deans and the schools, and that is a cluster hire initiative focused on the topic of race in America. So faculty members who are doing research looking at the effects of race in America, and of course, looking at it from the standpoint of how do we then take that knowledge, that information, have impact in positive ways on racial factors that determine economic outcomes, that determine health outcomes, and so many other areas. And that those recruitment processes are underway. We launched within the School of Medicine, School of Engineering, an initiative focused on the next generation of academic leaders. So junior faculty searches, particularly being inclusive of and reaching out and identifying faculty candidates from underrepresented groups. And that process, there was a symposium a couple of months ago that has yielded a number of candidates, and there are discussions going on right now with several of them by individual departments. And those of us in the dean's office, both in engineering and medicine, are very much involved in nurturing and supporting those discussions as they move forward. Already, many of our departments in the School of Medicine have, even prior to the tragic murder of George Floyd and the renewed attention on the effects of race on outcomes in all aspects of life and well-being. Even before that tragic event, a lot of our departments have begun to focus much more proactively on recruitment of faculty from underrepresented groups. And at the university, whereas before, for trainees, postdocs, graduate students, we had rarely entertained the option of hiring someone who was a postdoc here, for example, into a university tenure line position. We always have had UTL searches at the junior faculty level be national searches. Now with the support of the provost for candidates from underrepresented groups who are doing outstanding work here as postdocs, would be great candidates for a faculty member, independent of the fact that they did their postdoc or their graduate work here at Stanford. We now are actively engaging in discussions with them about appointment to our faculty. I mean, we were training students and postdocs from underrepresented backgrounds, and they were going to other institutions and building their careers in momentous ways. That's fine, but shouldn't some of them be staying here? We certainly hope they will. Those are some of the initiatives. There will undoubtedly be more as well.
And we were lucky to get one of those candidates, and hopefully we'll get several others, but one of them is a postdoc that's going to be joining us in the fall, and we're excited about that. And one of the other things that the center and the department have done is we wanted to bring people in from college level, and we're having a summer program. We had a huge success of over 1,000 applicants for not enough spots, but we will be doing this virtually, and we're really excited about bringing underrepresented minorities in, to Stanford so that we can, get them excited and engaged even earlier than that. But yes, I'm very excited about some of these new programs. So another question we had was, what are your thoughts on what Stanford Medicine can do proactively to increase active community engagement, partnerships, and trust in science, particularly in underserved communities?
It's a great question. Several things we've been doing, but for all these areas, we welcome feedback from anyone and everyone on what things we could be doing, what we could be doing more, and how we could be doing what we're doing more effectively. But let me just mention a few things we've done. We've had several webinars and discussion sessions in Spanish, open to the broad community, discussing COVID-19, discussing vaccinations in Spanish. We've also reached out to communities that are historically underserved. The vaccine clinic that we opened just a couple of weeks ago in East San Jose, with information sessions and ultimately administering doses of vaccine in the communities that have had very high rates of COVID and in communities that have been underserved with health and healthcare in the past. I think all of us, each of us as individual leaders, as individual faculty, have opportunities to communicate. I've tried during COVID through a number of national media appearances to talk about what the virus is, what we know prevents its spread, talk about vaccines, and answer questions that people might have about concerns they may have over either transmission or so-called non-pharmacological interventions, but really trying to communicate in ways that are meaningful in communities far beyond our world here at a major research university. And each of us can play an effective role in doing that in our own way and through whatever organizations we happen to interface or interact with. I think that's a way that we ultimately, it does worry me a lot that we are in a very anti-science period right now. And I think coming out of it is going to require a sustained area of focus on talking about what science is, what it isn't, what it can do, and what it can't do.
I agree. And I think we have some very talented community engaged types of people in our groups. And I'm hoping that we can overcome some of those concerns that we have had in the past. And, it's just going to take work. And I think that, COVID is an example of the difficulties. And it's really been so evident of where the disparities really are around the country. And I'm hoping that that's just maybe one of the ways that we can move forward and do a better job at it, and working with the community partners that we've developed and the trust that we're gaining in the community. So you've already addressed a little bit about this, but I'm going to ask you again because this was one of the questions. Is there new technology currently being developed at Stanford that will help push the needle forward on health equity and precision and population health? And we talked a little bit about that, about the home testing and things like that, but Stanford has so many things going on. Maybe you can talk a little bit about it and toot our horn about those kinds of things and how they can be used in the population.
Yes, there are several things that come to mind. One is a study that we completed here through our Department of Medicine a couple of years ago, the Apple Heart Study, that was the largest cohort clinical study technologically enabled that I know of. We've enrolled over 400,000 people over the course of 9 to 11 months. And really to ask the question and evaluate the question that is, could the Apple Watch be used to detect the most common cardiac arrhythmia, that is atrial fibrillation? And the data showed that yes, indeed, it can be used for that purpose. Just the ability to do those sorts of trials, and with where we are and who we are, our interface and interactions with the technology firms, I think in their own ways, each of the big tech firms has an interest in health and healthcare. Now, for sure, there has to be, again, privacy protections, and the Apple Heart Study was set up. Everyone who participated in the study gave active consent. The ways in which the data were used was described in detail to all participants. We have to make sure, and I think that's one advantage of doing studies like that with Stanford, is you can rest assured that for studies to get through our IRB and our review process, they're going to protect the privacy of individuals. But I think technology has impacted every other sector of the economy profoundly over the past decade. I mean, the way we order goods and services, the way we do financial transactions are all radically different because of technology. And yet, technology has had comparatively little effect on health and healthcare. Now, it was propelled forward out of necessity during COVID, and virtual visits, of course, at one point last April, May, we were doing 70% of our outpatient visits as virtual visits because we had to. Now it's 30 to 40%, depending upon the specific clinic. But we still don't have the type of transformative impact of technology. If we just want to take a restricted area of health and say medical care and say hospital outpatient care, people still cannot transport their medical records around in a facile way. Right. We're still using CDs to transmit images, and that just needs to stop. There are ways that we can protect and absolutely must protect privacy, but at the same time, when a person desires their CT scan or their MRI to be sent to another physician or another healthcare organization, they shouldn't have to go pick the CD from the office
Or a fax machine.
or a fax machine. Yeah, we're the only industry that uses fax
I
machines.
know, I thought they were non-existent anymore.
I know you have to go to the Computer History Museum, or you have to go to one of the nursing units at any hospital in
That's
America and
right.
find them.
That's right. All right, we're running out of time, and I have one last thing. Is there anything that you think we didn't cover that you want to share in the remaining few minutes?
Well, I want to share foremost a message of hope. This has been, I don't need to say this has been an extraordinarily challenging, trying year for everyone. And certainly that includes everyone at Stanford. And I want to thank the people who have devoted so much dedication, time, and energy to our university, to each other. We need to continue to take care of ourselves, and we need to take care of each other. We're starting to see the glimpse of the light at the end of the tunnel for COVID, but we're not out of the tunnel yet. And we need to keep being safe, keep supporting each other. And I couldn't be more proud of the people in our community, the way they've responded this past year, and the way I know we're going to continue to support each other in the days, weeks, and months ahead. And I guess, Melissa, I would close with a question to you, and tell us about the seminar series moving forward. I'm really excited to join
We
in.
are too. And so I think we have a slide to put up that has a description of the next three. And our goal is really to work with, as I said earlier, to work with different centers and institutes around the campus. And the three that we have scheduled so far is one on precision population approach to reducing COVID disparities. We don't lose sight of what we've been going through for the last year. And we're working with PCOR, which is one of our sister departments really in the policy. So PCOR is policy related, and we'll be working with them on a symposium. And then we're going to be working with the King Center, who are part of economics, looking at harnessing digital technologies to advance global precision health and development. So we're really excited about that. And we're working with the with HAI Center on artificial intelligence for precision population health. So we're really taking this to see how this goes. We're going to do smaller 40, probably 90-minute presentations where we bring in people from each of the centers locally and having another prominent speaker from outside so that people can start knowing what's going on here at Stanford, but also us knowing what each other are doing, because it only helps to build collaborations and for all of us to when we see synergy, let's take that opportunity to harness it and to really build programs across the institution. Just like you said, Stanford has so much to offer, and I think we really need to see how we can build these programs together. And I'm very excited about it. Obviously, I'm from cancer. We would like to do something related to precision health and cancer. And so I think there's so many opportunities. And if people have ideas, please send them to us. And we really want to think about how we can work together across the campus. And Dean Miner, I just want to thank you so much for participating and making this happen. And I'm glad that I was the first one to be able to talk to you a little bit about your book. And it was fascinating for me to read. And I'm just really happy to be here and to be part of the School of Medicine and the excitement that we have now and going into the future. So thank you.
Thank you very much for the great work that you and your colleagues are doing, and for inviting me to be with you here today. I've really enjoyed it.
Thank you. Me too. Thanks for taking the time.